Okay, sir, just start.
Good evening, friends. In this general club, we are discussing a study that is antibiotic treatment for 7 days versus 14 days in patient with bloodstream infection. It is commonly known as balance trial. Dr. Anjusha, who is a DNB trainee for critical care, she is going to present this study. Over to you, Dr. Anjusha.
Thank you, sir. Good evening, all. Thank you, Young Indian Intensivist team, for giving this opportunity. So, we as intensivists are very familiar with the term bloodstream infections, being the most common infections within the intensive care unit. On a daily basis, we deal with different kinds of infection, and most of it affecting up to 15% of the critically ill patients, with an estimated death of about 2.9 million per year worldwide. The bloodstream infections are also the major contributors of antibiotic overconsumption within the ICUs. With an associated substantial mortality and morbidity, the prompt initiation of an adequate antibiotic therapy may be one of the most important predictors of the patient survival. We as intensivists, we know what if we come across an infection empirically, or it may be a culture report based on what antibiotic we should start, the frequency, the dose, everything. But what about the duration? How long we should continue the antibiotic treatment? Unfortunately, the optimal duration of therapy for primary BSI and BSA secondary to major system infections has been poorly defined. The National Survey of Canadian Infectious Diseases and Critical Care Physicians, they published that the single most common recommendation of antibiotic duration was 14 days. But the durations of 7 or 10 days were also recommended by nearly half of the responders. With little evidence, mainly the prolonged courses are still being commonly used. The current guidelines also recommend the range of about 7 to 14 days of antibiotic duration. The general recommendation by the Surviving Sepsis campaign, this is that 7 to 10 days of antibiotic coverage is likely to sufficient for more serious infection associated with sepsis and septic shock. But they also note that it can be reduced or it can be prolonged as well. But it again is a weak recommendation with low quality of evidence. With so many numbers, like how long we should treat, whether it is a 7, 10, 14, there has been so many studies published regarding the duration of the antibiotics. So how long we should continue the antibiotic for the bloodstream infections. One such study was published by Yahweh et al. In 604 patients. They included in patients with gram-negative bacteremia who were afebrile and hemodynamically stable. They had randomized to receive 7 days as an intervention group and 14 days for control group. Their primary outcome at 90 days were all-cause mortality, clinical failure, readmission. With a non-inferiority margin of 10%, they published that the result was non-inferior. That is, there was not much difference between duration of 7 days of antibiotic course compared to the 14 days of antibiotic course. Similar studies has been published on comparison between 7 days and the 14 days course. That is a short course and the long or extended course of antibiotic use. Other one is Molina et al. They published a study to prove that 7-day course of antibiotics for bloodstream infections caused by the enterobacteriaceae allow a reduction in patient exposure to antibiotics, but which was similar to 14 days with a similar clinical outcome. And after that, there are a number of RCTs published with the comparison from 14 days with 7 days of antibiotic duration. And the recent REGARD-VAP trial on ventilator-associated pneumonia, they conducted the study to test more or less, I would say, ultra short or 3 to 5 days duration of antibiotic course. So with all these things in things or all these RCTs in our hand, I just compiled the few data with the last three major RCTs comparing 7 days versus 14 days by Yahav et al., Wondak, Molina et al. Most of them, I wouldn't say most of them, all of the studies were in favor of the non-inferiority of a 7-day antibiotic course compared to the 14 days course. In a study in 2023 by Soker et al., they also published that there was no evidence for a survival benefit of longer, that is more than 10 days versus shorter treatment course in ICU patients with bacteremia. Even though these RCTs have documented the non-inferiority of shorter durations of treatment, that is 7 days or less, there was a lot of limitations to generalizing the results for the previous trials, such as many of them excluded patients with accompanying bacteremia. They have focused on uncomplicated bacteremia. The sample size were not so significant, and they were unable to detect or exclude clinically important effects. With all these things in mind, the balance trial has been published, which is our topic for today. The balance trial is actually the bacteremia antibiotic length actually needed for clinical effectiveness, a randomized control trial. They aim to test 7 days of antibiotic treatment as compared with 14 days of treatment in patient with a bloodstream infection. The original article was published on November 2024 in NEJM. They have conducted the study in a span of almost 8.5 years from October 17, 2014 to May 5th of 2023. The authors of the trial are the balance investigators, including the Canadian Critical Care Trials Group, the Association of Medical Microbiology and Infectious Disease Canada Clinical Research Network, the Australian and New Zealand Intensive Care Society Clinical Trial Group, the Australasian Society of Infectious Diseases Clinical Research Network. Before launching the actual RCT, the balance authors, especially Nick Denman et al., they have published a pilot trial in 2018 as the 7 versus 14 days of antibiotic treatment for critically ill patients with bloodstream infection. That was more in focus of ICU patients. But after the success publication of this trial, they published another pilot study in 2020, including ICU as well as non-ICU, that is ward patients as well. So after publishing about three parallel pilot studies, their intention was if they prove the non-inferiority or the betterment of 7-day antibiotic course, it would be a paradigm shift in antibiotic duration course and all. So in the introduction part of the paper, they have very well described why there is a debate still going on between the short course antibiotic treatment and the excessive duration of treatment. Traditionally, the short course antibiotic treatment has been believed that it could result in clinical failure. If the duration is less, it might result in clinical failure, and it can cause relapsing infection. It may also lead to resistance in the culprit pathogen. On the other hand, the excessive duration of treatment is associated with avoidable adverse events, especially the Clostridium difficile infection, development of resistance among non-target bacteria. Above all, with more duration, it comes with an excess cost as well. So the hypothesis of this study was 7 days of treatment would be non-inferior to 14 days of treatment with respect to mortality and would confer benefits including the decrease in antimicrobial exposure, complication, and resistance. So let's just go into the paper in detail. Coming to the trial design, setting, and oversight. Balance trial is an investigator-initiated, multi-center, open-label, randomized control, non-inferiority trial with assessing 7 days of antibiotic treatment with in hospitalized patients. The study was conducted in 74 hospital sites in 7 countries with the maximum contribution from, as you can see, it's from Canada. Almost 75% of the population was taken from Canada, followed by Australia. The trial was approved by the Institutional Review Board at each participating site. They had obtained informed consent from patients or agreement from their substitute decision makers before the enrollment. The study has been overseen by a steering committee and an independent data and safety monitoring committee. Coming to the inclusion criteria, they have included all the patients in the intensive care unit or non-intensive care unit, that is the ward, at the time the blood culture is drawn or reported to be positive, and if the patient has a positive blood culture with the pathogenic bacteria. They have excluded patients who had previously enrolled in the trial and patients who were severely immunocompromised, that is neutropenia less than 500 per millimeter cube, or were receiving immunosuppressive treatment after a solid organ transplantation or hematopoietic cell transplantation. Patients, those who are having prosthetic heart walls or endovascular grafts, and if they have documented or suspected infectious syndrome for which prolonged treatment was necessary, such as endocarditis, osteomyelitis, septic arthritis, undrained abscess, or unremoved prostatic associated infection, those who need prolonged antibiotic treatment were excluded from the study. Apart from that, all the positive culture with the common contaminants such as corns were excluded, and Staph aureus or Staph luganosis bacteremia were also excluded. Bacteremia from rare organism that required prolonged receipt of treatment was also excluded from the study, along with that fungemia. So coming to the randomization, it was a web-based randomization with variable block sizes. It was stratified according to hospital site and admission to ICU or hospital ward. They randomly assigned in a 1:1 ratio to receive a shorter duration, that is 7 days, or a longer duration, that is 14 days, of adequate antibiotic treatment. The adequate was defined from their paper as antibiotic therapy to which the organism was susceptible according to the local laboratory reports. So, out of the 36,000 the patient were eligible for assessed, 13,597 patients were eligible for the randomization, and out of which 3,631 patients underwent randomization, and they have assigned it into 1,824 patients were assigned to the 7-day group, and 1,807 patients were assigned to the 14-day group. Daily assessments of adherence was conducted, and the reasons for non-adherence was also recorded. The selection of specific antibiotics, doses, and frequency, and the route of delivery, they were at the discretion of the treating clinician. In the balance trial, there was no placebo controls, but they aimed to minimize the bias by concealing group assignments until day 7 of the adequate treatment. Coming to the outcome measures, the primary outcome was death from any cause by 90 days after diagnosis of the bloodstream infection. It is defined by the date of the positive index blood culture. The secondary outcomes were death in the hospital, death in the ICU among the patients enrolled in the ICU or admitted to the ICU after the diagnosis of a bloodstream infection, relapse of bacteremia with the same organism that had caused the original infection, allergy to the antibiotic and adverse events, Clostridium difficile infection in the hospital, secondary infection or colonization with the antimicrobial resistant organisms in the hospital, length of stay in the ICU and number of ICU free days, length of stay in the hospital and number of hospital free days, duration of invasive mechanical ventilation and number of ventilation free days is also included in the secondary outcome. Number of antibiotic free days are also included, and the duration of vasopressor use and the number of vasopressor free days during the course of the study. Coming to the statistical analysis, the target sample size was 3,626. It's a larger sample size, of course. Based on anticipated baseline 90-day mortality of 22% from previous trials and a non-inferiority margin of no more than 4 percentage points. The authors specifically mentioned that considering the 10% non-inferiority margin in the previous studies, they have included a lesser non-inferiority margin, that is 4%, with an 80% power at a one-sided alpha level of 2.5%, accounting for a maximum of 5% close to follow-up. Coming to the analysis, the primary analysis were done by an intention to treat principle. They have also conducted per protocol as well as a modified intention to intention to treat analysis. The per protocol analysis excluded all those who had more than 2-day difference. That is, more if it is extending or with less than the pre-specified 2-day extension. In modified intention to treat analysis, they have excluded patients who died before day 7 of the treatment. The adherence to treatment duration means receipt of adequate antibiotics for 7 plus or minus 2 days, which is in the shorter duration group. And in the longer duration group, the adherence was defined by 14 plus or minus 2 days. That is, in the shorter duration course, they accepted that 7 minus 2, 5 to 9 days of antibiotic treatment was acceptable. The pre-specified subgroup analysis was based on source of infection, location of enrollment, that is whether they were in ICU or not, regarding the gram stain, vasopressor use, and the Apache 2 score. Coming to the result proper, the first patient was enrolled in October 17, 2014, and the last patient was enrolled in May 5th, 2023. So it's a longer duration surgery. Among the 36,000 of patients assessed for eligibility, the 3,631 patients were randomized, and 1,824 patients were assigned to the 7-day group, as I've already mentioned, and 1,807 patients were assigned to the 14-day group, with 10 patients excluded from the short duration and 13 patients excluded from the longer duration. Intention to treat group comprised of 3,608 patients, out of which 1,814 were included in the intention to treat population, 1,794 were included in the intention to treat population, with 12 lost to follow up in short duration and 15 in long duration. That is a total of 21 patients were lost to follow up. Comprising all the data, finally, 1,370 were included in the per protocol analysis, and 1,483 patients were included in the per protocol analysis in the 14-day course. Coming to the comparison between the baseline characteristics of 7-day versus 14-day group, the authors have mentioned that all the baseline characteristics were similar. Let's just check into it. Most of the participants were male, with like, I wouldn't say it, just most of, almost half of them were male, female was there. With a median age of 70, most of the patients were elderly, of course, and 55% patients were enrolled from the ICU. Compared to the ward, in ward, patients allocated from ward, it was 45%. So comparing that, 55% of the patients of bloodstream infection was enrolled from the ICU. And regarding the coexisting condition, most of the patients were reported to have diabetes mellitus. And the source of acquisition of bacteremia, 75% of infection was community acquired, and followed by 13.4% from the ward, and ICU acquired infections were 11%. The source of bacteremia, which is one thing to be noted, urinary tract infection comprised almost half, 42% of the infection reported for UTI. But regarding 7-day and 14-day, there was not much difference. But comprising all the data, almost 50% of the infection they treated or they included were from the UTI, followed by intra-abdominal or hepatobiliary infection, lung infections, vascular catheter, skin and soft tissue, and some other unidentified infections as well. Comparing the type of bacteria, 71% of them were monomicrobial gram-negative bacteria, followed by gram-positive, followed by the polymicrobial bacteria. The most commonly isolated pathogen was E. coli, 44% from the short duration course group, and 43% from the 14-day group. Coming to the primary outcome, death from any cause at 90 days from the date of collection of index positive blood culture. The authors reported that 7-day group was non-inferior with a difference of minus 1.6%. They included the 95% confidence interval as minus 4 to 0.8. The intention to treat comprised of 14.5% of mortality in 7-day group and 16.1% of mortality in 14 days group. So there was no difference in pre-specified subgroups, which I will come in the coming slides. So just let's look into the graph. Considering the delta, that is a non-inferiority margin of 4, and considering the risk difference is 0, most of the studies in the intention to treat, in the per protocol, and the modified intention to treat, the graph comes left to the 0. That is, it is proving that the 7 days is non-inferior compared to the 14-day group. Coming to the non-adherence to the protocol, that means the receipt of antibiotics for longer or shorter duration than the assigned number of plus or minus 2 days. I have already mentioned that the adherence was defined by 7 plus or minus 2 in the 7-day duration, 7-day antibiotic group, and 14 plus or minus 2 in the 14-day group. But in 7-day group, surprisingly, 23.9% of the patient was non-adherent. That is, they had to either cut short the duration, or they have to go extended duration of treatment of 23.9% 7-day group. And out of which 23.1 percentage was extended duration of extended from 7-day group. And in the 14-day group, of course, it was almost 17 percentage with the 10.7 percentage extended duration. So one thing we can notice, 23.1 percentage, which is almost like one fourth of non-adherence. So it would be little doubtful to how, like for example, if the 7-day course, if it is already extended, acceptable days was 7 plus 2 9. If they again extended it to like plus 2 or plus 3, it of course comes into a 12-day duration of 12-day duration of short course group. But if we think in the other way around, the 14-day group also has been specified for acceptable level of plus or minus 2, that is with a range of 12 to 16. But if the non-adherence with the 23.1% is non-adherence, most of the, or I wouldn't say most of, but almost one fourth of them might be overlapping. So there would be definitely be a confusion whether it is a 7-day group or a 14-day group. Let's just specifically explain that in the limitation part and all. So the median duration of the 7-day group was 8 days with an interquartile range of 7 to 1. And the 14-day group comprised of a median duration of 14 days. Coming to the comparison of 7 versus 14 days of secondary outcomes, there was significant difference in median hospital length of stay. That there was a difference of about 1 day, and median hospital free days by day 28. There was a difference of 2 days compared to 7 versus 14. And median number of antibiotic free days were also significantly different, with a difference of 5 days was reported by the authors compared to 7 versus 14 days. But there was no significant difference in hospital mortality or median ICU length of stay or median days of vasopressor use, median days on whether patient was on mechanical ventilation or not, or relapse rate of bacteremia, the Clostridial difficile infection. Even though there was not much difference between the 7-day or 14-day group of Clostridial difficile infection, they did reported 1.7 percentage of Clostridial difficile infection in 7-day group, and 2 percentage in the 14-day group. There was not much significant difference in secondary infection or colonization with other antimicrobial resistant organisms as well. Coming to the subgroup and secondary analysis as a part of the study, they also reported that there were all these things were similar, including the Apache, vasopressor use, and the type of bacteremia, whether it be urinary tract, vascular catheter. Most of them comes into the non-inferiority margin, with an exception few like vascular catheter. And in Apache score more than 25, they did cross the non-inferiority margin, uh, explaining it to be as non-conclusive data. But most of the other secondary analysis parameters were in non-inferior in the 7-day compared to the 14-day. Coming to the discussion part, the 90-day mortality rates among patients with the bloodstream infections in the balance trial. The 7-day arm comprised of 14.5 percentage and 16.1 percentage in the 14-day arm. The non-inferiority established across the intention to treat, modified intention to treat, and per protocol analysis as per the orders. They in the discussion part they also described that the three well conducted smaller randomized clinical trials, they compared 7-day treatment in the BSI, which I have already mentioned in the initial slides. They also published that the non-inferiority of the shorter 7-day treatment. But authors of balance trial also emphasize that all these RCTs enrolled fewer patients. They used larger non-inferiority margin, that is 10 percentage, and they excluded patients in the ICU. We, as intensivists, we are probably looking into the data or trials which are more in favor of ICU patients. Balance trial investigators also set up a meta-analysis comparing all the three trials which I have mentioned in the earlier slides. Yahav in 2019, Wondak in 2022, Molina in 2022. Comparing all these RCTs with the balance trial, uh, most of the uh, most of the sample size or the more of the weight of the pool is from the balance trial, comprising of 87.1% of the data is provided by the balance trial. Coming to the strength of the balance trial, as as I felt, it's a pragmatic design with a patient-centered outcome, of course. Inclusion of ward patient increases the generalizability because they have included both ward as well as ICU patient, not just focusing on the ward or not just focusing on the ICU patients. It's a multi-center international RCT, of course, the largest trial looking at an antibiotic duration and included wide variety of pathogenic bacteria because most of the other studies mention only gram negative or only gram positive, but they balance trial has included all the gram negative, gram positive, polymicrobial, all the possible infections were included. But some common bacteria not included, such as Staph aureus, which represents a large proportion of BSI with high mortality and morbidity. But in the inclusion exclusion criteria, they didn't include. They excluded Staph aureus species, which is almost second most common cause of mortality in ICU. That is one thing to be noticed. Coming strengths again, attrition was very minimal. 0.5% withdrew the consent, that is 7 in the intervention group and 10 in the control group, and only 0.7% lost to follow up. And all the baseline characteristics were similar similar like age, comorbidities, the disease severity, the frailty score. They managed to include all the patients with a similar baseline characteristics, and the intention to treat analysis supported by the per protocol and modified intention to treat analysis to mitigate the non-adherence or protocol deviations, being a non-inferiority trial and with 23 percentage of non-adherence. It's a little bit questionable, but since supported by the per protocol and the modified intention to treat, they managed it. The clinicians are blinded to allocation up until 7 days before being instructed to continue or cease the antibiotics to avoid influencing antibiotic choices and clinician decision making. And they are also include an objective primary outcome, that is 90-day mortality, which measures partly mitigate an open label design because we don't have a placebo, of course. Coming to the weaknesses, as I already mentioned in the initial slide, predominantly the population from Canadian hospitals. 75% of the population were included from the Canadian hospitals, followed by Australia. And considering antibiotic treatment a very prime part in the ICU, and even though 10% inferiority margin was described by prior trials, some would say to accurately establish as a non-inferiority trial, 4% margin can be considered as too high. And above all, out of the infections they have mentioned, UTIs made up 40%, 42.3% to be exact, almost about half of the population infected with UTI. And non-adherent rate was, as I already told, too high, about 24% in the 7-day group and 17% in the 14-day group. And the per protocol analysis was similar to overall results. And there was no mention of whether there were patients who were already on antibiotics prior to index positive blood culture. And if they were, whether these would have ultimately treated the BSA, that also we don't know. And they also mentioned that daily visits by research team was done. So I guess since there is no placebo, this daily visits by research team, even though it's a clinician-based trial, daily visits might of course lead to performance bias since we being clinicians, if there is an extra fever or any symptomatic deterioration, we will have a tendency to increase the antibiotic the duration or change the antibiotic duration, antibiotic treatment. So this thing has not been specifically mentioned. So I think this can lead to performance bias, of course. So after the publish in the end, the authors concluded that among hospitalized patients with bloodstream infection, antibiotic treatment for 7 days was non-inferior to treatment for 14 days. With this conclusion, they also believe that this non-inferiority can be generalized to other ICUs as well, considering the 4% inferiority margin and being it a large randomized trial. But they also mentioned in the last note that further trials need to be conducted because we are not considering it as a superior trial. It's again a non-inferior trial comparing the 7 and 14 days of. So, according to the authors, they are more specifically emphasizing that the 7 days was non-inferior to treatment for 14 days. So should we move into the critically appraisal part?
Yeah, continue with the critical appraisal, then we'll discuss.
So as I have mentioned regarding the study, let's just go into the paper as such. Uh, I have included a very low data for the appraisal, just regarding study validity, methodology, result, and generalizability. Coming to the study validity, first of all, was the purpose of the study conveyed plainly and rationally, of course. The author from introduction to discussion part, apart from the balance RCT, in the three previous pilot study as well, they have specifically conveyed why they wanted to continue the study or why they wanted to do the study to compare 7 and 14 days of antibiotic duration. But the objectives of the study clearly stated, of course, it was stated as clear. And was a study design stated and adequately described? Of course, they have specifically mentioned it's a multi-center randomized non-inferiority trial. Coming to the methodology part of the paper, was trial protocol and statistical analysis plan published before conclusion of enrollment? Of course. Was there blinding? No. Since it is a non-inferiority trial and since we are dealing with bloodstream infection with high-end organisms and all, it being a clinician-driven study, the blinding was not so possible. But they did it by concealing the group till 7 day of antibiotic, whether to stop at 7 day or continue the 14 days. That was the only thing they could do to avoid the possible blinding. Was funder involved? Yes. It was funded by the Canadian Institute of Research, Health Research and others, but they didn't have any direct impact on the study, of course. Was there a control population or a comparison group identical in all aspects? Yes, of course. In the methodology part, they have beautifully described all the baseline characteristics and regarding whether the ventilation days, hospital days, the comorbidities, all those things were identical. And were the baseline characters are similar, of course. Possible bias, yes, I think since they mentioned that the daily visits of clinician, since it's a clinician-driven study, daily visits of the clinician was allowed. So it can possibly lead to, not it can, it will possibly, it will lead to performance bias, of course. To the results. The sample size estimation and power calculation was, they have mentioned all these things with an 80 percentage power and how they derived the sample size calculation with a 22 percentage mortality rate from the previous trials. Basic data were adequately described, yes, and outcome measures, both primary outcome and secondary outcome were adequately described. Uh, P values are not included in the data, but confidence interval was enough, of course. So all these things were described either in confidence interval part or interquartile range. And they have also mentioned dropout or missing data, but they didn't mention why there was dropout but they have managed to do it with an intention to treat and per protocol analysis. So that part has been settled. Uh, so the important part, the generalizability, was study limitation discussed, of course. Even though I felt like they were more into strength part rather than limitations, because by reading the paper in the discussion part, I felt like they're more of comparing the other trials that they did so and so. Their non-inferiority margin was 10 percentage. The sample size was low. Ours was also largest trial so far and a low non-inferiority margin. But even though all these things are acceptable, but of course there was limitations. And so the last and final, are they study results applicable to local population? Of course, the intention of this journal club is to identify whether all these trials or the discussed trial is applicable to local population or in my ICU. So I would say I wouldn't just jump into start from a 7 day course from the next day onwards, because uh, I will just consider the studies population were entirely different from, because all the population were from first world countries. India being in a developing country, and with cost effective issue and all that, that's one thing to be considered. And since it's a clinician based trial, and we being clinicians on changing our perspective on if it was a no symptom or infection by antibiotic duration and all. I wouldn't say I'll just start from next day of this implement this trial on Pramagana, but with this large population size, and I would say I'll just consider in my mind. I'll just keep that the 7 day course can be considered. Uh, that's it. Thank you.
Good, excellent. In fact, Dr. Anjusha presented the paper very well. She started ground for the description of this concern point, 7 days treatment versus 14 days treatment in the bacteremia, how the things started and what were the previous trials, and the aim and object of this trial and what was the background was nicely described by Dr. Anjusha. And the description is also very lucid to touch up all the important points which reader needs to remember or needs to take into the consideration when analyzing the paper, one from the clinical aspect and second from the level of the evidence, what we call is the critical appraisal. So we need to really keep the things balanced. One is the clinical appraisal and the second is the a paper appraisal as such from the quality of their research. So one thing is very sure, this paper is very well designed, appropriately uh, taken consideration for how to prove their point with the selection of the design of the study. So this is a randomized trial, non-inferiority and randomization by block variable blocks. And if our viewer interested in the previous general club, we discussed the various methods of the randomization, what is the plain randomization and what is the block randomization. Just to again quickly recap, where our sample size is small and we want to really divide our population into 1:1 division in the group, then better to go for the block randomization. And block again can be variable, variable especially like a 4 uh, sample size block, 6 sample size block, and you keep on varying this. And blocks among the similar structure of your uh, subjects, or in this is the like ICUs or ICU population, like a ward to ward, small ICU to small ICU, large ICU to large ICU. That was it. Now next come to the randomization done and then non-inferiority trial. So Dr. Anjusha, can you tell us very briefly about the what does it mean by the non-inferiority trial, and what are the salient feature? Why can't we do the superiority trial for this topic?
Uh, um, since trials are can be just simply classified into either it can be a superior trial or an equivocal or non-inferior trial. So this trial is non-inferior because the fact that it doesn't prove that it is inferior and it doesn't prove that it is inferior. They are just comparing the fact that one study or one group is not worse than the other. They are not proving that it is not superior or it is not worse. To consider it as worse, they have to go with the placebo, because in this study, either they have to just continue with some group has to be given antibiotic, or to prove that other group should not be receive antibiotic. But considering the bloodstream infection and the dynamicity of ICU and the patient hemodynamics and infection status, placebo of course will not be much applicable in this study, I guess. So non-inferiority basically tries to prove that one group is not worse than the other. But so in such clinician-oriented studies and larger sample size studies, non-inferiority will be better to prove that one thing is not worse than the other. But one disadvantage of that can be if again in the first trial they compared 7 versus 14 day with a non-inferiority margin of 10 percentage. We frank with a 10 percentage margin. If the 75 percentage of if 20 percentage mortality was the considering 20% mortality was the primary outcome in the first trial, up to 30%, considering 10 as a non-inferiority margin, up to 30 can be considered, because up to 30 of mortality can be considered as a non-inferiority. But if we consider the same, if we compare the same study with the another study, or again if we increase the non-inferiority margin, the 30 percentage mortality may be compared with the increasing it as 10 percentage, they can accept the 30 to 40 can be accepted. But by continuous comparison of the 7 day versus 14 day, at the end, after so many studies, a huge difference can occur. It's actually called biocreep. And because of that, that is one disadvantage of a non-inferiority tile. But to prove that it is superior, of course, we want to use placebo. But I guess in this type of clinician-oriented antibiotic-based studies, using placebo will not be that much preferable, sir.
Yeah. So yes, yeah, you described correctly. Basically,
Anjusha,
where
can
the
you stop the share screen? Stop your share screen, please.
Oh, sure.
so if there is a patient safety is concerned, so if two interventions are there, and if you want to really prove the R, A is the initial and the B is the now under investigate intervention. So preferably, if you are having a liberty to prove both the way, either B is equal to A or B is better than the previous A, or it may end up with the B is lesser or the may be harmful to this thing. That is a completely freedom over there. So we can, or you can plan for the superiority where your hypothesis is the B is actually better than the A. That is your research hypothesis. Technically, if you pursue that hypothesis, then you have to treat these two interventions separately in the research. So theoretically is A intervention, compare with the control group without intervention and get the result. B intervention, compare with the without intervention and get the result, and the result is actually compared. Then only you can show a superior. And because both the things are in front of each other, then how you can say who is the superior? Then only this thing is already intervention which is there. So another which you are trying to prove is the non-inferior. So that's why whenever there is a safety issue is concerned, you can't go for the controlled population. Like placebo is one of the way. Technically, the more technical word is a controlled population, where the no intervention has to be done, which is not possible in such type of clinical practice. Theoretically, what happens if you give the no treatment versus 7 days treatment, and another group no treatment versus 14 days treatment, and see the how the mortality, that is the theoretically superiority trial we can, but we can't. One thing I would like to correct, when you say 10% inferiority margins, that is the your 10% of your consideration level, not the open one. So when you give the example, suppose 20% mortality is there, then the 10% of the 20% is your inferior, not the open 30% versus 30%. So whatever you take the baseline mortality or differences in your trial openly in any other infinity, and here is the mortality. So if we say our study population baseline mortality, we considering our trial is the 20%, that means up to 22% will take it as a similar kind of a non-inferior. That is the meaning of the 10% margins. Or in here is the you can say 4% means 4% of the 20%. So that is of course that it do. The problem here is now trial is of course the from the trial perspective point of view is reasonably good trial, but will always good trial lead to a actual conclusion which is there in the world or in the universe? May or may not be possible, though your study is excellent. So I'll discuss this thing is in this trial three term were used typically: per protocol analysis, intention to
Intention.
treat analysis, and modified intention to treat. Can you little bit elaborate what was that?
Sir, intention to treat in simple words, uh, the patients who are all randomized, they'll be all included in the study for final analysis, whether they have received the treatment or not. But the per protocol analysis is those who have already adhered to the protocol. That is, they received 7 plus or in this trial, it is 7 plus or minus 2 days, and 14 plus or minus 2 days in the 14-day limb. They'll only be included in the per protocol analysis. But an intention to treat means all the patients who are included in the randomization will be analyzed, whether they have received the treatment or not received the treatment, whether they were adherent, non-adherent, nothing matters. They in this balance trial, they have also included a modified intention to treat trial, which they mentioned it as they have removed all the patient who died before 7 days of treatment. That is, they couldn't because their primary outcome was 90-day of mortality. Because to fulfill the criteria of the study, or to specifically mention it as a positive study, they needed to uh, follow the patient till 90 days. But before that, if patient expired or I hope discharge or demise or whatever it is, they have excluded all these patients, and those who stay till they could follow till 90 days, that only they included in the modified intention to treat analysis.
Yeah. So you're right. More precise words. Per protocol analysis is you start your research, randomize, and finally at the end, what are the patient you are getting for the analysis? So here, after randomization, then there may be a during study, some patient withdraw their consent and all these things. Some patient may lost to follow up. All there may be multifactorial. Eventually, you get in this. You have seen the in last I think 700 something in one, and to begin with the 800 plus patients, 8,000 plus patients were there. So what you lost the patients or your results, if you analyze purely, then it is a per protocol analysis. Immediately after once the patient is subjected to randomization, I'm not saying the eligibility criteria and the withdrawal. Even somebody is not giving consent, then it's still okay. Someone give the consent and subjected to the randomization. From that point, till the completion of the study, they will be analyzed in their respective group. So there may be a question how? That is a statistical provision for that. But you have to analyze. Say, for example, you randomize, and this thing is even you start your intervention and patient withdraw the consent because they are free to withdraw the consent at any point of time. Still, they will be kept for the analysis. Immaterial whether the intervention has been done. I'm giving a highest point from where the patient can actually removed from your study group, but still, and obviously subsequently the patient during trial they can withdraw, they can die. So once somebody die on the third day, then what will you assume, whether it would be a 7 day or the 14 days because they didn't complete their respective intervention duration, and then they later on lost to follow up and all this thing. So you, irrespective of that, then it is a intention to treat. So intention to treat here is not the clinical treatment. Here is in the research language, every your once the randomization done, every your finding or every data you are having intention to treat that data. Your treatment the data means you're taking the data for the analysis. You can make a modification based upon the making your result meaningful. Then it was a modified intention to treat. What is difference between modified and the per protocol is even the modified certain things you can alter. You will not take the certain patients for the analysis, but it will be a generalized for both the group and for that point only. Like in this thing, I think mortality less than 3 days or less than 7 days, they eventually exclude. So still the few patients actually taken out from the analysis, but you can't take it as a per protocol. With per protocol, actually it's happening irrespective. There may be a more patient in one group, maybe a less patient. This thing is because you wanted to make your analysis meaningful way, so that you can make a certain modification. In this paper, example is the less than, but there may be a different examples over there. Now, of course, you describe whether we can use this thing in ICU or not. Technically, after going detail into this study, actually it is not the primarily ICU. Of course, as a human tendency in the researcher also, whatever they do for their research and all these things, even there is a limitation, they can project it as their strength. So that is the human tendency, because this study actually becomes hybrid over there. 45% patients from the ward and 55% patients from the ICU. So technically it is a limitation to say that neither we can have this concept, those patients which we consider from the ward only or from the ICU only, because almost a 50%. But somebody can take it as their strength because we have taken both the side. But technically here this strength is maybe strength from the clinical trial point of view, but for the clinician now it becomes a limitation for them, especially those towards the reduction. And those clinicians who are treating the ward patient, they can take it as an advantage over there. Despite the ICU patient, the shorter duration was non-inferior. So it's up to a reader or the person who is the user for this information. They actually take this information, whether it is a strength or limitation for their perspective from their users. So that is the one of the major foundation for the selection of the patient. Make intensivist specifically to hold on, see the things. Of course, this is a good study to give the signals. There may be a possibility. Some can think of shorter duration. Of course, right now, in which patient, what is the right way to do it, then it is okay. but not the every patient, because 55%. And then the second important thing you mentioned, you notice is the main ground here. Of course, there is no fault for the author also here. He clearly said a bacteremia, not the sepsis as such. And he didn't actually talk much about the sepsis. We can assume there may be some patient of, because neither he excluded the sepsis patient nor he's saying these are the criteria which, but we assume because the table showed a uses of vasopressor and all these things, so we assume there may be some patient of sepsis also. But what the patient we are seeing mostly, when we say a bacteremia and in the ICU setting, most of these patients are sepsis patient. Or if they are not sepsis, then the rest of the body organ system is so much affected than making them anyways serious or ill over there. We can understand this fact by indirect also, because bloodstream infection and sepsis and all this, they are having a mortality to the tune of the 30%, 40%, and roughly 25%, whereas in our is in this is the baseline 15% only. So we can again say not only the number, the contribution and all these things is not true representative of the ICU patients. And it is further when the subgroup analysis. And again, apart from the patient, source of infection mainly from the UTI. So again, these are the UTI patient, either they was in the ward, even in the ICU, they are not really that much sick in comparison to the patient who are having a bloodstream infection from the other source, and is clearly evident in the subgroup analysis. When you see the subgroup analysis, you can show that particular slide where the subgroup analysis of the different sources of this thing is. When we take the lung into consideration, then it crossing the midline. When we take the vascular infection consideration, it crossing the midline. And even the other, you can see, in fact, do in other way, you see who are the lines which is a crossing the midline. So you can from upside use first line crossing is Apache more than 25. These are the ICU patients where the Apache, when the moment Apache more than 25, then midline is crossed. Clinical fragility score, more sick than midline is crossed. Vascular catheter, yes. Urinary tract, it didn't cross. Lung infection, it is crossed. Even for others, it is crossed, or even undefined and unknown. So of course, this is not their primary endpoint, and the primarily what I can make the conclusion from my perspective is bloodstream infection secondary to the urinary tract infection, probably 7 days is non-inferior to them. With this, we can make this statement where we can almost clear those patients who are having a bloodstream infection secondary to the urinary tract infection. Probably we can think of in clinical practice 7 days. Even this thing, rest of this we can't not even think from our general perspective. From the paper itself is not very much robust for the other infections. Of course, that is not the primary endpoints. So primary endpoints is all cause mortality. So of course, now you can stop the slide presentation. So here one more this thing, of course, we most of the time. So what do you mean by primary endpoint? When we say this is the primary endpoint. So here now 90 days mortality is the primary endpoint. Why not 28 days? Here 28 days is a secondary endpoint in this trial.
Yes.
So
Because
what?
because I guess sir, in mostly in ICU studies and all, Most of the things has been explained in a 28-day mortality state. Since they have included ward patients, they might be stable.
That
So
is the
they
logic, but when we say it is here 28% mortality is also there. So why can't say it is a primary? So technically, the primary endpoints is the based upon that where your study population was calculated. So when power calculation was done for the 90 days mortality, then it would become a primary endpoint 90 days mortality. If it is powered for 28 days mortality, then the primary endpoint would be 28 days mortality. If it is powered for the hospital mortality, then the primary endpoint would be the hospital mortality. If it is powered for the clearance of bloodstream infection, then the primary endpoint. So primary is not the just the logic kind of a this thing. Logic is which point you select. So one is the primary endpoint, and second is the clinical important endpoints. So depending upon the point you select, and you make the that would be a primary endpoints. And of course, uh, this trial, especially the 7 days trial, 20 almost 24% of the patient actually becomes the other
14.
group patients, because 2 days allowed and more than that, then they eventually they become the other group patient and analyze here only. So of course, at this point, you are not comfortable to practice in routinely over there. So then what is the important of this paper? Can we discard it immediately, reject it? What is the importance of the all this exercise? Researcher done, published the paper, NEJM came out with this paper, and we are also discussing. So what end result we get from this information?
Sir, it's a largest, I would say, the sample size were almost in thousands. So the population they included to consider this trial was huge. So according to them, this can be generalized according to the authors. But considering in a population from India in a developing country, uh, we can consider, so as you already told, especially in UTI, it proves that it's in a non-inferiority trial. For specific infections, we can consider thinking of okay, 7 day would be enough for infection, but being again the study was also clinician driven. There might be variations for duration of antibiotic. So on a daily basis, considering the patient's clinical condition, hemodynamic status, and all, again we'll have a tendency to increase the duration and all. So I wouldn't say this study can be just discarded. That is not at all the part. But we can just consider maybe after so many trials and all whether it does whether it comes as an evidence, or we can maybe start to practice the thing. But at this point of time, with this single trial, we can just change our clinical practice from tomorrow, that I'll just start from 7 days, stop the antibiotic after 7 days, even if the patient clinical condition deteriorate, or septicemia or the source control hasn't been done and the patient deteriorates. I'll stop it at 7 days. That cannot be done, of course. But for mild infection, or especially like in UTIs and all, we might consider for reducing it to 7 day 7 days. And again, in our ICU setup, even in not just in a single ICU, in a just in a state in many ICU, the protocol might be very different. So we cannot just stick to this protocol. Of course, it will vary with the clinician's perspective. But I will definitely will not discard this or reject this trial. But I will just consider when I come across another septic bloodstream infection, this thing will of course will be kept in mind.
Yeah. So, especially the medical science, modern medical science is actually developed based upon the how the science take the information and the evidence, and today's evidence actually make the base for the another evidence. So, as if now the things are very much regulated in the medical practice. Even a one clinical trial may not, you may not change the your routine clinical practice, because now we are having a so much provision for that. Even a trial is eventually, so how the practice or routine practice changes. So from the trials, so maybe a multiple trial, a few trials gives the signals, then multiple trials comes to, then we are having a similar signals with the good strength, and eventually it is subjected towards the some subject or the specific societies or peer group, and they analyze all the evidences after their a detailed and predefined method for analysis, which is a very much objective, not the subjective. Based upon that, they make the recommendation. Once the recommendation comes, and again the recommendation is a very much kind of a variable in their strength. So there may be a weak recommendation, there may be a moderate recommendation, there may be a high recommendation. Based upon that, you, especially when the highest recommendation, typically the class 1, then only you can change your routine clinical practice, routine, individually, of course. So how will I'll take this paper is, it is a one of the a better evidence to the previous researchers is having a, the logic is there, because once you started the 2 week, the started things were initially were the arbitrarily and based upon the certain clinicians their experience. They could have been 4 week also initially, then 3 week, and so that is the way. And now the people are doing the trial, so some signals are getting, but still we don't know how consistently and who are those patients. So this trial becomes again the base for the further trial to really knowing the patients in what way, till consistent signals and the good signals comes, and then subjected to the come into the recommendation. Till now this paper is used for the further trial. Till now that paper is used for the individual practice in the certain condition, the certain patients, where the clinical and the clinical clinicians uh, decisions is primarily, and even it is always primary, even the trial is the clinicians based only. So it will give you a little bit of more strength for the clinicians to execute their clinical decisions for the shorter therapy, but that would be primarily for their clinical perspective, not just for the paper that was the end for added for you. So these are the ways our science is actually evolving all the time, and we are collecting more and more. I give you two example, where one is of course evidence based how the things, and actually we reach to that level. And one example over there is whatever we think evidence based medicine is not really uh, it's not absolute in this senses. Say for example, causing malaria from the plasmodium. How did we know? Based upon the researches only. Initially, it is believed to be from the air, bad air, then the mosquito. So you keep on this thing, and then finally you identify the organism. How you identify it? Based upon these trials only. So that evidence based, and then you crack, and finally you treat and the control based upon that only. So how much precision you get because of the way you do a clinical trials and generate the evidences and comes to the evidence based medicine, that is the pro evidence based. I can give you another example, like suppose if you do a trial on the earth surface for the very precise dimensions of the surface over there, to know the how the surface over the earth, maybe a 10 feet by 10 feet your surface a land over there, immaterial. If you do a millions of your experiment, you may not come to any conclusion. Of course you will not be able to prove earth is a sphere, but once you come out from the earth and in the space and you see the earth is a sphere, So here your evidence-based medicine may not be lead anywhere. Immaterial, you will having a highest sample size. So that is the way, because and not the problem of the evidence base is the actually sometimes tool are not corrected. The tool are not correct one. So you are actually applying the irrelevant or incorrect tool. So your conclusion may not be relevant. And ultimate aim is your conclusion is to unfold the hidden information existing in the universe by your this thing is. So sometime it tool may fail. Ultimately sometime you can directly see over there. So if you try to prove the how the surface of the earth by making the very systematic multiple examples in the tune of the billions examples over there, sample size increase to the billion, so that your false negative and all this thing, but still it will not give you a that much precise result. Whereas the experience based incidents, astrologist just come out from the surface of the earth and he can or she can see a completely over there, that is a purely experience based at that moment. So these are the pros and cons over there. So with this I think we discussed this paper as well as the very much useful in the clinical practice. In fact, I'll suggest everybody to read that paper, not only for this thing is how to really see the bloodstream infection, why they excluded the certain patients. So that's why the staphylococcus aureus bloodstream infection, even the 14 days may not be enough. So your clinical practice is also getting better once you read over there how to approach, what are the way to look at in clinical practice. So it actually increases your clinical practice also. uh, why? Because those clinical practice which are used in the clinical trial, they are reasonably foolproof in terms of the patient safety. In clinical practice you may do so many things who is nobody is going to see you every day what you are doing. It may be harmful for the patient, but those clinical practice in the clinical trial, they are reasonably highest level of standard. At least they may not be highest level, but at least they can't harm the patient. So you can have your insight what you are doing in the day-to-day practice may not be a directly result to the conclusion of the trial, but you see their methodology, it will definitely give you an insight from the clinician's perspective point of view and add to the clinical knowledge. With this, Dr. Tapesh, do you want to ask anything?
I think that's wonderful, sir. So, shall we close it, sir, with your permission then?
Yes,
As it
yes,
was?
sure, sure. I think we discuss in detail and everything was discussed. So thank you, Dr. Anjusha, for a great presentation and good discussion.
Thank you.
Thank you, Dr. Tapesh. Just close the session.